Good morning and welcome to our 33rd Town Hall Conversation. It's great to see everybody again, and as always I'd like to thank the members of the Society for Leading Medicine for presenting this and for all of their support. We actually, if you missed last month, we now have new chairs for the next 2 years, so I want to thank Dr. Waverly Peaks and Adam Peaks, as well as Kristen and John Berger, for agreeing to take on those important roles, and I know they're going to lead a great educational series as well as great functions over the next couple of years. We have an interesting program today. We're joined by Dr. Stuart Core, who is the Director of Innovation Systems Engineering in the Methodist DeBakey Heart and Vascular Center, and the leader of what we call MIRIN, that's M-I-R-I-N. We love our acronyms around here. It's the Methodist Institute for Robotics, Imaging, and Navigation. So he's going to be really fascinating to hear from today. We also have Dr. Alan Lumsden, who is chair of our Department of Cardiovascular Surgery within the Methodist DeBakey Heart and Vascular Center. But he's always also really the driving force behind all of our education initiatives in the Methodist DeBakey Heart and Vascular Center with CV Education, including this studio. This was really his brainchild. So even though I'm the host today, I'm actually, I think, a guest in Dr. Lumsden's house today. Now, if you want to participate, as always, in this conversation, you can text your questions directly, and we'll try to get to as many of those as we can. You text the word DeBakey to 37607, and then ask the question. You can also post questions in the live stream chat box, and we have Dr. Chris Ibarra, who is lead in the CV Education and Innovation team, who'll be there typing furiously to answer any of your questions. So we're going to start today with Dr. Lumsden. Dr. Lumsden, why don't you tell us a little more about many of the innovations that you all are carrying on? We started out with Dr. DeBakey and an innovative mindset, and you're propelling that forward.
Well, thank you, Mark, and you're a most welcome guest in this, and taking it to a whole new level. I want to talk really about the educational programs. Some of these started with DeBakey Education, but Mighty has always been an incredible location for us. Mighty, I hope all of you have had the chance to go up to Mighty. If you've not, well, we need to get you up there. It's in the 5th floor of the Research Institute. But Mighty was really not my idea. Credit for that goes to Dr. Barbara Bass. And I think Mark can remember this, the original concept was in an old operating room in what we call the West Pavilion, but the idea really took legs. I think Mr. Bookout basically was a real champion of it, and as the Research Institute was going up, the proposal was build another floor on there, don't slow down the building, and let's really build what I think is the best hands-on training center that exists anywhere in the world. And so Barbara moved on up to DC, and at that point in time I was asked to kind of fill her shoes, pretty big shoes to fill. But Mighty really, we expanded it, is really much bigger than just a place where you go to do kind of hands-on training, but really think of it basically as a concept and a center that we can not only bring people from around the country, but we can also basically use it for training folks in our service line, and showcase it as a platform. And so Mighty, I think of, if you look at the diagram on your left, it's like almost like a core lab. What do we mean by core lab? In research parlance, we think of as a core lab as somewhere you grow cells, for example, and all the researchers can kind of move into it. So this is a core educational facility. And I'll show you some of our competition, but honestly, the way I sell this place is that I think in the Walter Tower, we just built what I think is the best hands-on cardiovascular clinical care tower that exists, immediately adjacent to the world's best training center. That's unique, and I'll try to show you some of that. And so we think of Mighty as that core lab that we have certainly leveraged, and we want to basically do some of the things that we've done in DeBakey and expand it out to the other centers of excellence. But there's also other components of Mighty. When you have something as complicated in Mighty, and we'll take you on a little tour virtually through Mighty to kind of whet your appetite, it can serve so much more than this. You're going to hear from Dr. Core about robotics. The way I think about how we work here at Methodist, we're a clinical platform par excellence. And that's really, we talk about the three-legged stool of academia. There's the clinical leg, there's the research leg, the educational leg. They're all important. But one big leg that we've got is the clinical environment. You get that wrong, nothing else works. But if you get it right, then we can leverage, some of the amazing things that exist in the hospital, and we can build educational programs and research programs. And I'm going to kind of walk you through some of those things. So again, as you've often heard, at the center of all of this is taking care of patients. And that's a pretty expensive proposition these days, and the technology that Methodist affords us is just gigantic. In my world, it's imaging and what we call interventional operating rooms. But robotics, is an increasing part of where we spend money. And what Stuart's going to talk about is how we can potentially leverage this and mimic something that's done at Imperial College in London by building research and education around robotics. So again, the idea is that most of our physicians are working pretty hard. We're not real interested in doing a whole lot more, but if we can leverage what we do in taking care of patients into these other missions, then so much the better. And that's really where this comes along. Part of this for us really was building the Walter Tower. Walter Tower was built with cameras in all the operating room. Why is that important? Because we've done a great job at building the structure here. We're not particularly good at going out and showing the world what we're doing, and we want to be able to do that. It's part really why this studio was built, is we want to leverage what we're doing and showcase this to the world. We can do this by recording procedures, editing them, and presenting them. I'll show you this YouTube channel a little bit later. And when you've got basically these research infrastructure that's going on, and I'll give you an example of percutaneous valves, it starts off as a research program. Then it gets approved. Then these device companies have to train the world in how to use these devices. Well, guess what? If they've come down here, they've met our researchers, they've gone through Mighty, they've gone through Methodist, then guess where the training is going to take place? And that's really where we want to be. We want these device companies to use Mighty as a training venture to train the United States and beyond the United States. And that's the kind of structure that we've got here that allows us to leverage basically our clinical care activities on a daily basis. And so that is kind of the way I think about this. Now, Mighty is a fascinating place, but we're not the only game in town, and so we need to keep an eye on basically the other centres. And the big centres that are actually doing this, on the left is the Centre for the Future of Surgery. That's at UCS, SD in San Diego. And probably the biggest competition we've got comes from a place called CAMELS, which is University of South Florida. But you go, and on the right is really the biggest cardiovascular operation. There's a relationship with New York Presbyterian and Columbia, and this is the Cardiovascular Research Foundation, and they have a center like Mighty called Skirball Center. Interestingly, the two people who lead the Skirball Center were both recruited from Methodist Hospital. They actually both worked with Al Reisner in his lab. At the time, basically, of the separation from Baylor, they left and went up there. But they are uniquely positioned, basically, in moving that forward. And so this is, but what we're unique really is because of this. And I think this is truly unparalleled, that I can work taking care of my patients, and as I said, what I believe is the best cardiovascular clinical care tower that exists anywhere in the world at the moment. I'm immediately adjacent to the world's best hands-on training center. Most of these other centers I've showed you are not co-localized within the hospital. You got to get in a car, you got to drive an hour and a half from Manhattan over to New Jersey to get the Skirball Center. Here, companies can come into Mighty, have relationships with the physicians from the various different centers of excellence, watch them remotely, or walk over and watch cases that are being done in the operating room in the cath labs. And we have been overlaid in the cardiovascular world we have the biggest Siemens install in the world, and we have their cardiovascular imaging showcase center. And so all of these things multiply. They're synergistic and they multiply. I find it very difficult to explain to people who are not in Houston exactly what we've been up to and what we've achieved really in the past 20 years. Partly because it's a complex place, partly because it's in Texas Medical Center. But when I've been given a talk for an hour, and I'd say, can I take any questions? And the first question is, Dr. Lumsden, how long have you worked at Texas Heart Institute? I want to pull my hair out, but I think it just is a reflection that Texas Medical Center is a very difficult concept. But when we've brought people down here, when we've walked them through our organization, we've shown them places like Mighty, and we've talked about the vision of what is being created here, then they get it. And so that's part basically of our strategy, is to leverage places like Mighty to not only teach people, but indoctrinate them at the same time as they're down here. And by developing these remote communications capabilities like the studio, like YouTube channel, then that allows us to, as a force multiplier, to let people know what we're actually doing. And so the audiovisual integration is an important part of this. You can see in Mighty, the participation went way down during the pandemic. What I've just described to you is a wonderful setup. was not such a wonderful setup during the pandemic, because Mighty we treat as part of the hospital. Nobody felt like it was appropriate to say to families, you can't come in here when we're doing open heart surgery on your relative and yet be running training center at the same time. And so Mighty essentially had almost no utilization for a couple of years, but it's rebounded. We went through this switch, and we were very well positioned because we were already doing this. The studio was not a reflection on a reaction to COVID. It already existed, and we already had these platforms up and running that we could turn this on and grow it. So we never missed a beat in terms of getting our message out. We did miss a beat in terms of being able to get people down here. And I do think that's a fundamentally important part. But we're back, and we're basically up and running. And so Mighty is a place, but can be a much broader concept in terms of putting all of these different pieces together. And one of them is the simulation center. And so, again, we want not only to have a great simulation center, but I think it's important that we showcase basically what the simulation center is like. And I'm going to basically take you into this link, and we can walk you around this. And so this is one way that we can bring Mighty to the world. Again, we bring people down here from industry. They want to go back, and they want to basically show their colleagues why they should be bringing things to Mighty. And this is an example of how you can do this. This is on the Mighty website. Here's Barbara basically still up here. This is in full VR, so that you can drive around it, and it lets you walk the walk of what Mighty actually looks like. And so now we take you back into this site where we can do multiple hands-on training with, frankly, the latest and greatest of equipment really that is in here. We have CAT scanners, we have MRI scanners, and all of this basically is a reflection of the interest that industry has in what we are doing really up in Mighty. And so go on the Mighty website, and you can take the opportunity of driving around in there. But we want to also be creative in education. And so what you're looking at here is a 3D streaming camera. We could put it right in the middle of this room, and you'll feel like you're part and parcel of this. Now, we're not going to do that in a conference, but we do want to do it in terms of surgery. And this is, again, a link up to our YouTube channel.
Intra-artery stenting.
And what you see on here
this piece is a fairly
I'll
complex
move
piece,
this forward just a little bit. The experience of being in an operating room with us. So I'm going to stop me talking for a minute, and that's hard. And so you want to be in the operating room? We're going to show you the operating room. So this is not a video. Do you want to see what the nurses is doing? So we'll show you the nurse. And here's the nurse on the table. You want to look in our hybrid room. This is Greg, who's the tech, and Brian. And so it's a great way of orienting people to this and interacting and bringing the experience of being in the cath lab or being in the case. This stuff up top doesn't exist in these operating rooms, just so we can virtually amplify this. Now, if you had an Oculus headset and you go into the Oculus Quest store, you're going to be standing in that room looking around it. You're not going to be driving the computer. You're just going to be using that headset and moving around. So let me go back to my presentation. And the point of this is we're trying to be forward viewing in terms of how we deliver these educational products to Houston, to Texas. And now, as I'll show you, we can get way beyond that. Social media is fundamentally important. It may drive us crazy, and we may be afraid of it, but it's very important. Our YouTube channel is, there's 2,500 videos on there. We'll show you this. We'll hit 100,000 subscribers this year, probably in June or July. And as you can see here, that's like 0.42% of all YouTube channels. Every vascular resident in the country, every cardiology resident in the country, every cardiovascular CT fellow in the country has used our YouTube channel. When they come here to interview, and when they do this, they all tell us they learned about Houston Methodist by looking at our YouTube channel. And you can see, that different, this is a site that gives you matrices and lets you kind of see how we can actually grow this. So right now, 2 days ago, we're at 92,000 subscribers. This is like 14.5 million views. This is easily the biggest cardiovascular YouTube channel next to ACC that's being run anywhere in the world. And I think in a way of getting our message out, this is how you amplify it. How do we know people see it? Because they communicate with us. And so how are we going to take this to the world? You can see a guy from South Africa said, I wanted to express my interest and gratitude to you for creating the platform and sharing your expertise. Bottom line is there are no ads on it. We get no revenue out of this because we don't really want ads kind of popping up all over it. But if you've got access to the internet anywhere in the world, you can watch our products. And another one from South Africa, and here's one from Afghanistan. And again, it kind of shows you how pervasive this actually is. Interesting story is one of my partners, Dr. Mahesh Ramchandani, was in Shanghai, and an Afghani surgeon came up and said, Dr. Ramchandani, it's so nice to see you. And he said, do I know you? He said, no, but I know you from the videos you've created. And he pulled a hard drive out of his pocket. Mark, this may make you cringe, and he said, you know what this is? I said, no. He said, this is Methodist in my pocket. It's a great name, because there's no YouTube in China. And so we think he was downloading all the videos and probably selling them. But it's a great name, Methodist in my pocket. It's a pretty interesting idea, and it kind of shows you how pervasive this is. So I'm not going to tell you about the broadcast studios, because you're kind of experiencing it at the moment. Very important during the pandemic for us to communicate. But all of this stuff that you see that's up there can also be used for product development. And I think that when you have such an endeavor, you have so much equipment, then what we want to do is create this idea basically of supporting the development of this content, but also kind of bringing in and expanding this for the development basically of a variety of different types of products. The imaging, the models can all be used for device testing. And it's one of the things that we really want to leverage as we go forward. Well, I think Houston in general, we are underperformed from the point of view of developing startup companies. And there's a lot of work. NMed, of course, is a platform that will help create these the startups for these CEOs. Mighty is an exceptional place for allowing startup companies to come in and to test their products, using a lot of things that really have already been created. And so I come back to, and I'll close with this slide, is really what we have in our hands is the entire continuity of product development. And I'm going to choose these two guys. I think we need to update the picture from Neil Kleiman. I think that's him from about 30 years ago. But Neil Kleiman and Mike Reardon are two of my partners. TAVR is the new device for treating the aortic valve. We did not get in the first trial. We did get in the second trial. These guys and all the people who support them knocked it out of the park in terms of the enrollment in that study. It was the single most lucrative, at that time, maybe in the place with COVID time, the most lucrative clinical trial that was brought into Methodist. It gives us prestige, it gives revenue, and what happened is, so they were the highest enrollers. That led them to be asked to be the principal investigators of the subsequent trials. And Mike Reardon in particular has been a national PI on probably 4 or 5 of these trials. Never does a Medtronic and a Boston Scientific have the same PI. It's like, they just don't talk to one another. The fact that Mike leveraged that into being able to run those trials, and what that means is when the trial gets completed and the data is reported, that is then published, and these presented and published by the PI. And Mike has got like 8 New England Journal publications out of that alone. That's the kind of exposure that we can't get. And as I said, what happens then is we go from training the trial sites to having to train the population of the United States. And once companies have seen Mighty, seen this connectivity that has been created, and seen how we can broadcast this, this is where they come and they bring people. And so I think that in this center, that entire continuity from the research through the clinical care and back into Mighty is unsurpassed anywhere in the United States. So to answer the question I was posed, how are we going to take this education to the world? I think we're doing it. What we want to do, and I'm tasked with, is trying to amplify this through the other centers of excellence. So Mark, thank you very much again for the opportunity to present.
Thank you, Alan. Thanks for the very interesting discussion. We'll get some questions at the end for both of you. So I'm going to turn things over to Dr. Kaur, who's going to talk to us about robotics and innovation in that realm.
Thank you, Dr. Boom. It's a pleasure to be here. So I'm going to jump straight into my first slide. So here at Houston Methodist, we're very lucky in a sense we have access to every single FDA-approved robotic system available, okay, from every specialty as well. So we have cardiovascular robotics, such as the Pheno system, the neuroanalytics system. Then we have the more familiar DaVinci and Intuitive system for urology, OBGYN, general, etc. And then we have neurosurgery and orthopedics. So it's not just DaVinci as a robotic system now. There's a lot of other systems coming on the market with new technologies, new capabilities. So one of the functions of Mirren is to pull all these key stakeholders together, understand what systems they're using, understand their bottlenecks, and look for new areas of innovation and research. And so that's why we kind of put together objectives and key results, in that we want to develop and integrate this robotic imaging and navigation technology into the hospital system. And our goal is to allow this for enhanced and precise delivery of patient care. And we're doing it in the setting of the age of the smart hospital. So what does the hospital of the future look like? And a couple of areas that we've been really keen on the last couple of years is image-guided robotics and extended reality. So we launched officially in 2021, and we're delighted to have our second annual symposium last year in October. And this gives you a little flavour of who we had there. So we had both industry and academia being present, and it's really important that we bring those two kind of backgrounds together, because we're not just innovating in a box, we're not just innovating academia or industry, we want to have a synergistic overlap. And one success story here, which I won't go into too much because they're going to give us a rundown pretty soon, is ABB Robotics. So they've relocated here to Texas Medical Center, and they want to get into healthcare. So long story short, we managed to introduce them to the pharmacy department here, and they've set up a collaboration with Dr. Bass and Dr. Badka, where they're using robotics to sort out all the unused medication. So it's low-hanging fruit, but high impact on our kind of internal workforce here. Now, if you want to get a better idea of what we're doing, please go to robotichealth.org. This is under construction, and this kind of is the central point for dissemination of our activities. So it talks about MIDI extended reality, the Center for Rapid Device Translation. And we use this, we actually coined the term robotic health ourselves. And it's not just robotics in surgery, it's robotics through the whole entire patient journey, from diagnosis to arriving at the hospital, to in the OR, outpatient center, at home. Like, where does robotics kind of fit into that entire patient journey? And we're delighted that last year, about this time last year, we had a robotics and image retreat. And this was put together by Dr. Sossman, Ned Jones, and Rebecca Hall here. And they actually matched up seed funding with Rice under the new president there, DeRoches. And we're delighted to award up to 11 or 12 seed awards, specifically for research and innovation over a 1-year period in robotics and image-guided navigation. So at this year's symposium, we're using that as an opportunity to disseminate and talk about results in those projects. So we're hoping, again, these will lead to grants, lead to new devices, new IP, etc. So really exciting stuff. Now, and one of those things, I mean, this is a quick example. Dr. Gabriel and Dr. Oviedo had a problem where when they're doing an anastomosis procedure in the OR, when they're pulling together vessels, it's hard for them to visualize exactly where they want to be. So they can only see like a certain aspect of that. They want to be able to see almost like a drone in there flying around. So they said, okay, this is our problem. Let's get some Rice students over. So we recreated the surgical condition at Mighty, and it was a pig kidney transplant. We had the students and the staff and the professors from Rice there. They understood the problem within a couple of hours. You know, we really understood it. And then it took about 10 minutes of myself and Dr. Ashok in one of the back rooms talking about a solution to actually, in the back of a napkin, draw a potential solution. So it was really low-hanging fruit in allowing this to happen, but it was so important because we have the capability of bringing in Rice academics and Texas A&M academics, etc., showing them the problem right in front of them, and it's a really nice, easy way to get solutions. Now, switching gear a little bit, I'm talking about extended reality here, and XR is an umbrella term for virtual, augmented, and mixed reality. So, as Dr. Lumsden was talking about, in the pandemic, our reality changed. Okay, we weren't able to pull people into Mighty. We couldn't do hands-on training sessions. It was pretty much at the same time that Facebook, who are known as Meta now, they released their Oculus Quest 2 system, the first fully immersive VR headset for under $300. So that kind of really got us intrigued. So we just pulled in literally every single piece of hardware available, from the Oculus Quest to the Vario XR3 to the HoloLens from Microsoft. But we also evaluated all the software and apps out there to see what works for us, what doesn't. And the result from that is a thing called the Mightyverse. You may have heard the Metaverse. Well, this is the Mightyverse. I'm going to play a little promo video there. Could you guys play a video, please?
At Houston Methodist, we are creating new realities for our patients, staff, and the global health community. Viewing the whole patient at a time. Exploring the heart from the inside out. Hands-on practice when you need it the most. Remote assistance for times of urgency. And if we are limited by our reality, we create a new one. Welcome to the Mightyverse.
So the Mightyverse, what is it? Well, we like to think that it's the first ever metaverse for medical innovation, and we really want to kind of take our hats off for that. And this has been a really joint effort here. Our development partner was Fundamental VR from the UK, and one of our collaborative partners was 3D Lifeprints. Rather than me trying to explain with words what it is, I'm going to show you another video of kind of what it looks like. Now, what it is though, it's a VR app. It's an app that you would download from the Oculus Quest store. You would install it on your VR headset like the Oculus Quest, and you'd be fully immersed in this virtual reality Mightyverse. So here's a little, can you play the video please? So that gives you a little visual overview of what it is, but I'm going to focus on the Heart and Vascular Center room that we have in the Mightyverse. So you have the user here, they're going up to the podium and they're accessing different types of content. All this content is available on the DeBakey CV Education YouTube channel, and you see the example here is an ascending sacral aneurysm. So that video is of a patient procedure here at Methodist, but what you see on the little podium in the background is a 3D model of a heart. That heart is the actual patient's heart. We went back into the MRI and CT scans and we took out that data, we segmented and rendered the heart, we colorized and texturized it. So that is literally the closest thing that you can have to holding that patient's heart in your hand. So again, you've got 3 people there, a few people in the background. These are from different geographical locations internationally. We have someone from Holland, UK, Portugal, 2 people from America in different time zones. Latency is superb, so there's no delay there. So what you're having here is one of our collaborators going up to you and handing off that patient's heart, and you can actually see here the diagnosis and the prognosis and see some little kind of aneurysms there. Again, there's nothing, you just can't get as close to this level of interaction using another platform. So we're really excited by where this is going. And again, if you want to give a presentation, you can go into what we're kind of collectively calling it the VR Bookout Auditorium, and you can see in the background, you can see the Research Institute, so it's kind of nestled in the heart of the Texas Medical Center in terms of viewing. So you're in there giving a presentation, you look back, this is like the big screen, so a big like theater, looking at the audience. Now you might see these emojis here. We all use emojis, we use them in text, and why do we use them? To enhance a level of interaction. So we're allowing the user to do that, but we also allow these other interactions as well, like you're going to see flying hearts here, for example. And this is one of the power in VR. It's the limit is really your imagination. You can start pulling in this gamified approach. You can start developing new worlds in here. So the final thing I want to show is kind of where the robotics and this image in VR kind of meet. So what you're looking at here is the Corindus CorPath GRX system. It's an endovascular robot. It allows the user, the surgeon, to be at a distance from the patient so that they're not being exposed to the X-ray fields. And I was thinking, well, hang on, why does that surgeon need to actually physically have interaction with the control system? So we completely got rid of that and we tested it out in an augmented reality approach. And so what you're seeing here is Dr. Lumsden. He has a Microsoft HoloLens headset on. but he's doing something with his hands. So to anyone else, it looks like, well, they're kind of confused, like what's going on there. But to Dr. Lumsden, what he's seeing, he is seeing this. This is an augmented reality build-up of that control system. Like, this is a virtual control system, essentially. He's driving the catheter, driving the guide wire. If he walks away, it just kind of shows you where it is in his kind of space. And all that range of motion, everything he's doing is being translated. And you'll see in a second, it's driving robotic arms here on the control system. And you'll see the guide wire. So this is a proof of concept that all it takes for a surgeon to do this type of surgery anywhere in the world is essentially a HoloLens headset. And we like to think that we're just scraping the surface of where this is going. And thank you very much.
Well, thank you again. Two very interesting presentations here. I've got a bunch of questions. I guess I'm going to jump right to one of the big questions, right? A lot of this is education that you're showing, but you were just showing a surgeon, I think, in the Netherlands, collaborating with a surgeon here. Where do you see this going from an actual clinical surgery perspective, right? If we zoom out, the U.S. system has Houston Methodists and a few other organizations like us, but then there's a lot of small, remote, rural hospitals. I mean, the care you get, the access to care you get, the emergency care you might get is tremendously different. And it seems to me this is a solution to some of those problems.
So Bill Klein was one of the guys who started Pumps and Pipes with me. He ran ExxonMobil Upstream Research, which at that time was over in Buffalo Speedway. Had $1 billion a year research budget and 600 PhDs. Thought, this is a guy I need to be working with. Well, he retired. And Bill actually moved 2.5, 3 hours away, and he said the decline in the quality of healthcare availability when you move into a rural area, in Texas, not that far from these big centers, was remarkable. And I think that one of the things I'm particularly interested in at the moment is virtual care. I mean, we're leaders in this also, as you know, but if you look at that robot, for example, stroke intervention has been transformed in the past 10 years. Now what you do is you got to put a catheter up into your brain and you suck the clot out. It is the single most cost-effective intervention that's ever been described in medicine because it stops you being paralyzed. Strokes don't necessarily kill you, they just maim you for the rest of your life. And so huge amounts of dollars have been put into trying to evaluate that. Now the problem is there's not enough stroke interventionalists. So you live in Houston, you're fine. You go to where Bill is, 3 hours away, you're not getting that level of care. So what is being looked, but that robot in particular was actually bought by Siemens because what they're thinking about is, can we position these robots? Could we have our stroke centers run those robots? You go to the nearest place, somebody needs to put a sheath inside your carotid artery somehow, and then let the stroke interventionalists run these robots, get the clot out of your brain. It's all about how long does it take from the event to getting the clot removed to save your brain. That's what this is all about. So this is one example. Now, reimbursement, legal, there's a whole slew of other things that come down after the technical feasibility of it. That's one example. I mean, other examples are that through the pandemic, because of our remote communication systems, we couldn't have reps or other people come in. I'll give you an example. There was a patient who was supposed to have one of those structural heart interventions. The proctor was coming down from Emory because there was something brand new. Emory wouldn't let him travel. And so because of the systems that we've got, we could turn it on. He proctored the entire procedure from Emory. And things like that had never really been done before. So I think there's all sorts of applications, for this. I don't know if people are going to be doing the operation other than very select situations like stroke.
So just to drill down on it a little further, you literally would look at, I assume in that setting, sort of geographic centers from an access standpoint to get people in quickly enough, let's say a small rural hospital. And they're going to need a highly trained nurse practitioner or a general surgeon or somebody there who can put catheters in, things like that. And literally they'll be the hands-on person while you, for example, or I mean in the case of the neuroscience one, somebody like Dr. Bretz would be doing a procedure like that from a center of excellence.
Exactly. Not the hard part, but the limiting step is you got to be able to get a tube that gives you access in the carotid artery. Well, that could be a local cardiologist, a local radiologist, could be a surgeon who just makes a little incision and cuts down, and then you have somebody like Gavin who would take over remotely. That's the concept of where this is going.
Wow, that's pretty amazing science fiction-y kind of stuff. You talked about latency, though, and then you mentioned it's almost eliminated. I remember there's been proof of concept of some transcontinental kinds of, of gallbladder surgery or appendix or something like that. I can't remember exactly, but latency is always the big issue. Latency being, hey, you need real-time feedback, right, to be able to be a surgeon. And when you're pulling on tissue, actually have tactile feedback that says I'm pulling on tissue and have it happen in real time, et cetera, et cetera. Has that been solved? Is that issue addressed, or is that still a technical limitation?
Very good question. There will always be a technical limitation, but there's a lot of solutions out there. For example, you've got AT&T and Verizon rolling out all their 5G services, so allow for more enhanced transmission, enhanced speed. You have the Elon Musk, the Starlink satellite, etc. I believe with the Siemens Corindus, they've done a study. I was actually in China, I believe, with 5G, and the latency was still good enough. And we've done our own study here at Woodlands.
So you're right on. You see me playing with those joysticks. The problem is if I move the joystick and the catheter doesn't move, you think, I didn't press the joystick hard enough. So you do another 2 or 3 times, and anything takes off. And so actually, this is an example of leveraging our system. We put that robot up at the Woodlands in a model. We didn't do it in a patient. And we ran it from downtown. You can actually we ran it from Mighty. You can build in latency. And so we ran it with a series of experiments doing carotids, coronaries, interventions to see what sort of latency was tolerable. It's about 500 milliseconds. Once you start getting beyond 500 milliseconds, it's a problem. But you can monitor the latency in these systems, so it alerts you if the latency is going up. But Stuart's exactly right. It's the 5G networks that are going to completely transform our ability to do this.
And just to add to that, pumps and pipes, for example, that's why we're pulling in NASA, because they have the same problem. Yeah. They're going back to moon probe, the Artemis.
Try to talk to Mars.
Correct.
Talk about latency,
So hopefully their solutions become our solutions.
Wow, fantastic. And for those of you who are not familiar with it, Pumps and Pipes was the brainchild of Dr. Lumsden. I know he sat on a plane with, I think, an engineer from one of the oil and gas companies, started realizing that everything he's doing, they're doing, and it's been going on for another dozen years or so? 15 years now that we've had this. And it puts together great minds from healthcare, from the oil and gas industry, from NASA, as Dr. Korb was talking about, and really a very exciting conference that happens. So, so we have a lot of specific questions from people about robotics. It always fascinates everybody. And it's either robotics or obviously sometimes minimally invasive techniques, a lot of what you were showing in your slides there, Dr. Lumsden. So when does a surgeon decide whether they can go in robotically versus through the chest, and i.e. cracking open the chest, for example, or in other cases, perhaps an abdomen or something else like that? How do you make those decisions?
So, fascinating question. Can you guys pull up? So let me show a video, because I knew one of these questions was coming on this. So let me borrow your pen for a minute, Mark. Minimally invasive surgery started off with putting let me run this first of all. This is a view through a surgical robot, okay? And 90% of the thoracic surgery that's done in our operating room, now the thoracic, we mean lungs and esophagus, we're not talking about cardiac per se here, is done with the robots. And this is what's the view look like. So I take the opportunity of jumping in and watching what they're doing, and said, to me it was like, what's that big beating thing at the back? Oh, that's the aorta. Well, they don't operate, they ignore the aorta. I said, you got to be kidding me, it's that easy to see. And so they gave me a little tour. And so you're looking at the left carotid artery, the descending thoracic, it's all right there. And so we in the cardiovascular world basically have kind of gotten a little bit behind the 8 ball. You can come back to me at this point in time. And so,
but to be clear, what we're looking at there, Alan, is through a couple small incisions.
Yep, couple of small incisions. It's got stereoscopic vision now, so you get 3D visualization of it. Go pull it back up for a minute, and I'll just run it forward. And so, again, the surgeon is sitting at a console. You don't have to wear. You don't have to stand between the operating. You could be sitting drinking a cup of coffee when you're doing this. And so for us older surgeons, probably can expand your durability for a period of time. And so they got their head in this console and they're looking at this. And what they're doing is manipulating in their hands. And so you can take that off, is that initially laparoscopic surgery, you put a scope in. So if this is my abdominal wall, you put a scope in. The weird thing is, if you want to look to the right, you have to move your hand to the left. It was exactly the opposite from the way that we learned. What this company did is it's called intuitive. And so what they did was they made it intuitive for the surgeon. You didn't have to think backwards. You just sat down and it's much like what you do in an operating room. And that was started by two guys. One's called Fred Moll, who started multiple companies. The other one was a guy called Dan Wallace, who was an aerospace engineer at Rice, went down and worked at NASA, and he built the wrist. It's the wrist that makes of the robot that makes this intuitive. And so it's much more like doing an operation now than it was doing laparoscopy. And I think some of us have missed that because we weren't trained in laparoscopy. Now we're hardwired going back to reevaluate this.
To be clear, that wrist is important because if you're going through a tube, you have very little articulation, right? Yep. You kind of can do like this, whereas that wrist at the end of it, which is effectively at the end of those instruments, literally can move around just like a surgeon's hands would.
That's the secret sauce for this robot. Yeah.
So if you've never had a chance to play with it, we can get you to Mighty sometime because you can actually play on one of the robots. I've done it. I'm very bad at it. You never want me to ever do your surgery, but it is actually quite amazing how quickly deft you can get at picking up small objects, moving things along.
So we now have one of the new robots up in Mighty because we have so much hospital activity that they put that robot up there really for training a priori our people, because normally you got to pull them out and send them somewhere. They want our people to use it, but it also gives us, number one, a platform for learning new procedures and to bring in people. And so that's all part of the development of this focus around robotics.
So with all of this, Dr. Court, we've got the engineering medicine program. One of the things I tout often, is we're an independent academic medical center, meaning we work with many different great institutions and we will pick and choose the best from them. And in this case, working with A&M, obviously great medical school, but an amazing engineering program, obviously top 10 in the country. Merging medicine and engineering, you've got to be pretty excited about what's coming through that. Some of the work that we've done research-wise, but some of the people who are being trained through that. As Alan said, we've got our first class coming out in a couple months. They'll go through their first match in about, 3-4 weeks will be their first match where they figure out where they go do their residency. So talk a little bit about that.
Yeah, I mean, the MA program is spectacular, and it's really exciting to see the first cohort graduate this year. They've been there for 4 or 5 years, whatever, and they're finally got through it. And it's really good talking with these students. Like, for example, there's two students in particular, Shara Kumar and Charles Foster. They came up and said, look, we're interested in VR, we want to do stuff. So, we got them working on the Mightyverse. They're doing use case scenarios. They're pulling in their other students to go through the Mightyverse to look at new ways of training for a surgeon, come up with ideas. And they're actually presenting that work at ACS in Chicago. So already, like first year, they're going to present a poster on the work. So they're really happy. There's a lot of students that really want to get engaged in robotics. They want hands-on, they want to engineer, okay? And I think that's going to be phase 2 of Mirren, is trying to build out an infrastructure, ideally on site or nearby, that is almost like a prototype engineering kind of space where you know where you go, there's people working on robotics projects, etc. So we're really hoping to link them into that. But really, if there's any MN students watching, for example, even at Mighty, there's a little intake form where they can express interest in robotic workshops. So if there's something happening and they sign up, we can reach out to them and say, hey, there's something coming along here, come and have a look.
That's great, and that's wonderful. We have a lot of specific questions here clinically, so I do want to make sure we get to those. So one of those, and I know this is near and dear to your heart, somebody asking about what we call a AAA or an aortic abdominal aneurysm. Are those done open? Are those done robotically? Or are they a little bit of both?
Yep. A little bit of both. Actually, I'm smiling. I just gave medicine grand rounds this morning on AAA. Is that used to be up until 15, 20 years ago, it was all done open. And then we get this endovascular revolution where you work inside the blood vessels and reline the inside of the blood vessels. Now we're kind of undergoing a little bit of realization that, they're not that durable. And so, and a lot of these patients don't need durability. It's a race between patient mortality and the durability of that repair. And so in an elderly patient who's high risk, absolutely is done with an endograft. And for example, in the UK now, there's just kind of done a national decision that if you are young and healthy, you're not going to be offered an endograft, you're going to be offered open repair. So
because it's got longer durability.
It's much more durable, and it's much less imaging intensive. You put these endografts in, you have to get a CAT scan probably once a year. And some people have abnormal kidney function, it's the radiation. So there's kind of a reevaluation. It's not going to go away. In fact, it's kind of expanding in the scope of the aorta that we can take on. But the open aortic repair is still there. And the question is, can we do it with a robot? Right. Because what's been done is that, it's interesting, general surgery, the lesson from them, they changed the way they do the operation, but did the same operation. We've completely changed the operation. And what we want to go back to is the DeBakey way that was proven to be durable, but doing a big open incision as a delivery system is just not acceptable.
Right, so to be clear, we're going from open up your entire abdomen, you got to get to the back, to the aorta, everything else, to doing it through the groin, basically, right, endovascularly. But those stents are for somebody who is 50 with a AAA is not going to last long enough, right? If you're 90 and limited life expectancy and can't survive that surgery, very difficult, makes a lot of sense. So now you're saying, we want to make a couple small little holes and do this robotically and have you go home a day or two later as opposed to big abdominal surgery.
That's I think there's so much movement that has taken place. I actually think we in the cardiovascular world have missed out on this. I mean, it's always been about bleeding control through these robots and an emergency, how do you convert? But having watched our thoracic surgeons, I am convinced that we need to re-engage in this, and we are.
Well, I mean, you bring up an interesting topic, which is how multidisciplinary we are. So I'm going to have a question in here after I give a little bit of a bit here. So if you look at some of the robotic surgery, it really started in gynecology. It started then in general surgery. Then robotic got into urology. So it's been a little later in the game with all of this. Interestingly, our new chair, who I'll show you everybody a photo a little bit later in my talk of OB-GYN, is a cancer surgeon who does robotic surgery and has done some pretty pivotal trials on kind of the pendulum swinging back and forth a little bit between robotic versus widely open. So my prelude to that is one of the beauties of this is putting together all these fields and great minds. Talk about some of the most exciting things that have happened, because you're talking to people in a different field. And then talk about Mighty and all of what we just saw today and how we broaden that to all of our other fields.
So one of the themes that we have in Pumps and Pipes one year was the other guy's toolkit, the other gal's toolkit. And we learn in silos, and that's a real problem in medicine. Is a lot of people, there are solutions for a lot of problems I've got, maybe in the operating room next door, but you never walk in there. And that's one of the things that we kind of want to encourage. Engineers are another example of this. Is that one of the challenges of Pumps and Pipes is there are a lot of smart people in the room, but we speak a fundamentally different language, and it's very easy not to communicate. And I think that's where people coming out of NMed and the likes are going to be able to be the translators between the engineering speak and the medicine speak. It's where we miss out on it. And so I think that Mighty as an area where people can be brought together is just hugely important. And encouraging people, I think that's the nice thing about the culture here is, I don't think anyone walking into Gavin Britz's operating room and say, hey, well, what is it you're doing with that imaging setup? And so I think there's a lot of gold, by increasing the interactions that we have. The robot actually was initially developed for cardiac. In fact, Randy Wolf, who's on our faculty here, was one of the original developers, but it was too hard. And so a urologist watched them and said, hey, maybe I could use this for the prostate. And that's where it took off. And then it went to GYN, general surgery, thoracic surgery. And so, it was fortuitous, but a lot of these advances are fortuitous to start with.
Well, when I hear you talk about walking in the operating room with Dr. Britz is our chair of neurosurgery. Every time I hear that, these two concocted another toy they want us to buy. But as you can see, we are replete with technology, which is one of the things that makes this so successful. And the Mightyverse, that's the first I heard of that now. That's pretty exciting. I love seeing all of that moving forward. I think robotics could even go so far as getting into the home at some point. Talk a little bit about how that might impact things. We certainly are going to end up with some hospital and home kinds of functions over time, because there's some aspects of hospital care that may actually function well in the home environment. It's a big movement nationally. Robotics is probably going to have to play a role in that.
Yeah, I've been thinking about that a lot the last couple of years. And I mean, I'll be totally honest, it's hard for me to actually think, what is the application? Like, what's the thing that a robot in the home can do? Like, what type of robotic system? Is it someone that cuts your grass, right? Is it someone that puts the dishes away? Or is it something that helps you go through cardiac rehab or exercise kind of routines, etc.? I think the biggest exciting thing for me is that thing that's going to come out that we just can't think about. Where it's going to be a couple of years where something comes out and we're like, oh my goodness, that's so obvious. Why didn't I think of that? Exactly. It's kind of like with AI, with ChatGPT, like all these AI things are coming up now. And they just popped out of nowhere almost. And I think the same thing's going to happen with robotics in the kind of home environment.
Well, it's exciting. And as many of you have seen, we do a lot around digital innovation here as well. Really trying, as we especially deal with issues around staff availability. We were talking about that as Dr. Lums and I walked in. There's a huge nursing shortage, technical shortage across the country. What we say is technology, our goal is to care for patients and do the things that only humans can do, and then let's find ways for technology to enhance that and to improve their lives as clinicians and nurses.
Yeah, so the investment in technology here, particularly in this digital innovation, is absolutely massive. And I'm going to appeal to my physician colleagues that said of this at my State of the Union address, it's time to go from passive resistance to active participation in this, because the investment in platforms is huge, and there's got to be something wrong with you if you don't see the opportunities that actually are. And so, for example, when I say to a physician, virtual nursing, oh my gosh, the first thing they're going to do, they're going to pull their head out and say, we just need to spend more money. But then when they understand the concept, the idea is that nurses spend a lot of time charting. That's been moved away from the bedside nurse to somebody who could be potentially at home or in our center, and increase the time that the bedside nurse spends doing exactly what Dr. Boom has just said, things that only humans can actually deliver. That's a phenomenal concept. This fall prevention program is using these video cameras to look at patterns. And a lot of this has been generated by Elon Musk and Tesla, these self-driving cars. This video analysis capability is all being driven by self-driving cars. And now we're using it in the operating rooms. We're using it to see patients when they start getting out of bed, so the nurse can go in there and prevent falls. So I think that every center of excellence here could have a subcomponent of it about virtual orthopedic care, virtual cardiovascular care. I think we got to bring the physicians along to do this.
But what you see really is this is the institution to do it, and we are driving that kind of innovation. So thank you both for a great lesson in how innovation gets used in education, in clinical care, and robotics, etc. So thank you both. Really a fascinating topic. Thanks again for hosting me in your home here, Alan. I'm going to give a quick, brief update on a few things at Houston Methodist. As always, since these started with COVID, I got to bring in COVID, but we're in a pretty good place now. You can see that famous curve there. We're kind of leveling off at a couple hundred patients. I think we are reaching a little bit of a plateau because the wastewater is also plateauing. So I don't think we're going to get to kind of the great low, those wonderful low levels we've had a couple times before, but probably going to be living with this kind of at this bubbling behind level. We still do have patients, as you see, in-house, a couple hundred, and many of them ill, although not ill to the level of ICU care that we've seen before. So again, kind of in the background, again, as I always say, use your common sense and individualize depending on your risk factors. I want to talk about a couple of things from Houston Methodist perspective. I always talk about, we will focus on the fundamentals and the awards will follow. And some of those awards, just kind of come a little bit out of left field. We don't know they're coming. And one of those is Forbes magazine actually does surveys of employees. We don't even really, frankly, understand the entire methodology, but they find employees of all these large employers and they survey them and then basically rank them. Couldn't have been more happy, especially during a time when we know there are staff shortages out there, when we're recovering from a pandemic, when it's been a rough time in healthcare the last couple of years, to be the #2 large employer in the country, the number one of any health system. You can see in the top 10 there, you can see Mayo Clinic as well as Cincinnati Children's also ranked. And actually, those are two of our employees there because the whole article was most of the article was about us and about healthcare being very prominent on the list. Dr. Lums and I were talking about that on the way in. I think it's because healthcare has passion and purpose, as I often talk about. And as we've come out of the pandemic, people see that purpose. They were a little tired, a little ragged. Now they're getting some recovery, and what you're seeing here is a focus on employees. Shout out to HEB, who we love, who is number 5 in the country as well. Similar one on Glassdoor, which also looks at best places to work, and a month ago or so we were notified we were on the top of their list. Health Grade's another one of these out there, put us at HMH, one of the 50 best hospitals in the country. And we are now one of only about 10 hospitals that have been on that list for 15 or more years straight. So huge kudos to the team here. And again, focusing on the fundamentals, those awards follow. I alluded to this before. Our Department of OB-GYN will have a new leader, Dr. Pedro Ramirez. We're delighted he'll be joining us. He is a gynecologic oncology specialist or oncologic surgeon, so he does all the different types of surgery, whether it's ovarian or uterine, etc. There, and will continue to build upon our outstanding program there. We're thrilled he's coming to us. Actually, what I was alluding to before is he did one of the pivotal trials, actually made the New England Journal of Medicine, really questioning the issue of when do you do robotic, when do you do open surgery, and which situation gives really the best outcomes. And so he will be a tremendous asset to our institution. And then last, I thought I'd show you a picture. We are building more great space. You heard about the Walter Tower and the transformational nature of the Walter Tower, which you see there. That's a view you're not probably used to looking at of the Walter Tower. But 2 weeks ago, we erected our very first tower crane to start going up. We've been working down right now. They've been drilling 5 miles cumulatively of concrete underground support for this building, and now it's just about to start going up. So, well, you know, these things go up very quickly once we start seeing them get vertical. So we're just very, very excited about that development, and that will continue to bring leading edge medicine to Houston Methodist Leading Medicine. So with that, I want to close today and thank everybody for being here as always. Thank Dr. Lumsden and Dr. Kaur and Dr. Ibarra, who is online live answering questions for you in the chat. Next month, we will be back on a normal Thursday. It will be Thursday, March 30th, and we'll have a conversation really with some of our otorhinolaryngology experts, so ENT, ear, nose, and throat, talking about 2 specific areas. One is hearing, which of course affects so many people, and lots of exciting things happening in that realm, as well as sleep apnea, which we year after year after year recognize how important sleep is and what a significant issue sleep apnea is. So I encourage you to tune in. It'll be a fascinating conversation. With that, stay safe, stay healthy, and look forward to seeing you next month.